co-conveners and the dignitaries who are here with us. Dr. Rujuta Mehta, who has been crafting this program and who has been designing this program for the entire year. Welcome, ma'am. I thank you very much for this opportunity and for helping us out. And Dr. Vikas Agashe, sir, for helping us liaise with today's organization, which is the World Academic Body on Infections in Orthopedics and Traumatology. Welcome, sir, and a big hi to Aditya, our dear friend. So my premise here is just a brief to introduce about the Bombay Orthopedic Society. This year we are in our 60th year of existence. Our society is growing stronger every day. It is because we are standing on the shoulders of the giants and the giants who have shaped our society in the last 60 years. We can see that two of our panelists feature very prominently in this list of orthopedic surgeons who have been acknowledged, who have published, and who are contributing immensely to orthopedics and orthopedic education nationally and internationally. It all started in Mumbai way back 60 years back when Dr. Rajek Katrak, who was the first orthopedic surgeon, established the first orthopedic unit in India in Wadia Children's Hospital, where Dr. Rujuta Mehta currently practices. He established academic teaching units at KM Hospital and a few other hospitals in Mumbai. And he was the first Indian to be awarded the honorary fellowship of the British Orthopedic Association. The society grew from strength to strength, and in the founding years, a group of very enthusiastic orthopedic surgeons, Dr. Katrak, along with Dr. Vora, Dr. Masalawala, Dr. Purke Mullah Firoz, established the first exclusive orthopedic association in India. And they were supported very ably by their colleagues, Dr. Talwalkar, Dr. Dholakia, Dr. Kini, who established a big role in, who sort of played a big role in establishing our society. They had regular clinical meetings, lecture programs, teaching programs, and held a national conference once in a year, and the first of which was held in 1966. We had traveling fellowships from the orthopedic section of the surgeons of the Association of the Surgeons of India. Subsequently, we saw rapid growth because more number of surgeons were trained. A lot of surgeons took interest in orthopedics, and they contributed immensely to the society. It has culminated to the point where we have a very active postgraduate teaching program, a fellowship program, observerships, and our annual conference, the WAIOT. We have got an active journal, which is going to be indexed in the DOAJ very soon, and it has generated a lot of interest amongst the juniors who submit here to sort of get recognition and get their work noticed. Another unique thing about our society is that we are one of the first ones, and probably a very few societies have done this for members and orthopedic surgeons worldwide, is that we have got a protocols app which is freely available on the App Store and the Android Store. This is basically a consenting app, and in this day and age of medical legal problems, two of our members have designed consents for various orthopedic and trauma procedures in great detail, along with illustrations, along with all the complications enlisted. And this enables the member to sort of electronically consent their particular patient. So it is very convenient. It is not only for the members, but it is for any orthopedic surgeon who chooses to use it. We do have a fund where we support research activities by our members. And notably, Dr. Agashe sir and his team have conducted a lot of practice-changing research in osteoarticular tuberculosis, which has been published. It's there on our website, and these articles are featuring very often in various teaching programs and journal clubs, and it has indeed changed the practice of a lot of orthopedic surgeons in the country. Where do we stand today? We influence a lot of orthopedic surgeons nationally, and we are very proud of that, and we would like to take that legacy forward. And therefore, we sort of inculcate and we try to incorporate newer techniques, newer teaching modalities, and newer sort of strategies to reach more and more orthopedic surgeons, especially where orthopedic teaching is required, or whoever requires academic support. In quest of that, this year we are doing 12 webinars with societies which are of repute worldwide. So these are webinars which have been conducted. There are certain master series which are flagship activities. We recently had one on upper limb malunions. The next one is going to be on lower limb malunions and non-unions. Talking about webinars, we had the webinars with the Bone and Joint Journal on chondrosarcoma. We had one with the Canadian Pediatric Orthopedic Society on the pediatric hip beyond the DDH. We had one with the Asia Pacific Orthopedic Association on a foot and ankle section. This one we are having with the World Association of Infection and Orthopedics and Traumatology. And the next one in August will be with the Singapore Society of Hand Surgeons on PIP joint fractures and wrist fractures. This is virtual, but we do go physically to various tier 2 cities where we collaborate with other orthopedic organizations and conduct medical education programs for a day or two. Recently, we had been to Gujarat, a neighboring state, and next one we would be going to another neighboring state in Chhattisgarh, Raipur, where we'll be talking about upper limb trauma. And there will be a postgraduate teaching program where faculty from Bombay would be traveling to the states nearby. We have live hand surgery symposium, 4 of them this year. So the one which went by was on hand surgeries, the videos of which are there on our YouTube channel. There were about 17 or 15 recorded live surgeries, which were being to about 17 cities all across the country where orthopedic surgeons sat. They watched the surgeries being and two-way question answer sessions were being conducted. The next one is going to be on foot and ankle. It will be on the September the 14th, and we hope that we get equally enthusiastic response for that. As we speak, the basic arthroplasty course is going on, and I've just been back from there. Another 33 people have registered for that. A very exhaustive 7-day course on basics of arthroplasty, which involves cadaver dissection, sawbone workshops, attending operation theaters, live surgeries, and of course, interaction with key opinion leaders and case-based discussion. Having said that, we would also like to invite all of you, all the delegates, all the people who are watching this, and each and every one of the faculty who is participating in today's webinar to our annual flagship event, which is the WAIOT, which will be conducted between the 26th to the 28th of December. Dr. Gautam Zaveri, who is our president, unfortunately couldn't be with us today, but he passes his regards and he warmly welcomes you to participate in this annual extravaganza. This year promises to be a bigger one. It promises to be a landmark one, and I would really wish that all of you could attend that and could participate in the conference with us. Having said that, I would not take any more time, and I would like to invite Dr. Rujuta Mehta to start the proceedings and welcome Dr. Agashe. Thank you very much.
Thank you very much, Ashish. It is indeed a very unique program that the Bombay Orthopedic Society is convening, and it is my absolute pleasure to introduce our own faculty members first as they hold the fort for this beautiful webinar today. Dr. Agashe is, of course, very dear and very well known to all of us, but when things are required, we must do it the right way. And therefore, I'd like to introduce him formally. His affiliations are that he's the head of Bone and Joint Infection Unit and consultant orthopedic surgeon of many years standing and experience at the PD Hinduja Hospital. He's a consultant orthopedic surgeon at his own Agashe Maternity and Surgical Nursing Home. He has mentioned only 30 publications here, but I'm sure he has many, many more in the pipeline and many more that we don't know of. He's been awarded prestigious positions and fellowships of the Bombay Orthopedic Society. He was the president of the Bombay Orthopedic Society from 2010 and 11. He's the chairman of the Infection Committee of the Indian Orthopedic Association, the advisor to the Infection Committee, Indian Orthopedic Association, the chairman Trauma Committee, Indian Orthopedic Association in 2019 and 20. And his noteworthy achievements, of course, are the Professor A.K. Das Oration at the West Bengal Orthopedic Association, Best Paper Award at the Third Congress of WAIOT in Miami, and awarded the Veteran Surgeons Forum at the WAIROC in 2023. The AAIS Ortho Excellence Award at the Pune Trauma Course, and awarded the Golden Jubilee Oration in the Indian Orthopedic Association 2019. But of course, these are just a few of his special attributes. But attention to detail and dedication to fight this modern epidemic of infection, and especially tuberculosis, are the two things that have really taken my heart. Welcome, Dr. Agashe, to this. Dr. Aditya Menon, of course, is a very young and budding orthopedic surgeon. He is affiliated to the PD Hinduja Hospital as a consultant in trauma and infections. He takes after his worthy mentor, that is Dr. Agashe. Again, over 30 publications in trauma and arthroplasty. He's had the BOS Hinduja Osteoarticular and TB Research Fellowship, and he's also done a fellowship at the Endo Clinic and Charité Hospital, Germany. And his noteworthy achievements are that he's been the country delegate for India at the EBJIS. Aditya, you would have to tell us what that is all about. And the honorary secretary of the infection section at the APOA. I will now request Dr. Agashe to please introduce our guests, our foreign faculty.
Thank you very much, Rujuta. At the outset, let me welcome all the friends from WAIOT and request Dr. Carlo Romano to tell us briefly about the WAIOT and its activities. Thank you very much.
Thank
Dear
you.
Carlo, please.
Thank you, Vikas. Thank you, Dr. Mehta, and all the team for this very welcome invitation. We are very honored to be here, and WAIOT is an association that is focused on bone and joint infection treatment, diagnosis, and research. I think many of you probably are also members of WAIOT, and I will just briefly show you a little bit the history of the association. This association was founded, is a very young one. It was founded in May 2017 in Vienna, Austria, by not more than 12 of us from different countries around the world, all interested in the field of musculoskeletal infections. Our mission was to bring together colleagues of various disciplines from all over the world interested in this particular field, to increase and share the knowledge in these difficult and challenging conditions, to support the research, to cooperate with existing national and international institutions and societies, and last but not least, to raise new awareness on the social and economical aspects of this very complex disease. Our vision is targeting scientific and humanitarian aspects worldwide, with a comprehensive website platform, flexible networking structure, inclusive and not exclusive perspective. We want all on board with us to share differences and visions. And we have a universal, free, and open access. And this is why we don't ask for membership fees, and everybody is welcome to register. It is possible through our website that you see here. Actually, we are the largest worldwide association focused on musculoskeletal infections, gathering more than 2,500 members from more than 100 countries. As you can see here, nearly all the globe has at least some member of WAIOT at the moment. We only are missing probably Antarctica. We are missing some parts of the Central Africa that we hope will join very soon. We, since the beginning, tried to use and take advantage of modern media and internet capabilities. You can see here our Instagram and LinkedIn links. And we have a newsletter that is sent monthly to all our members. And we have a editorial activity trying to publish shared papers. Publication fees are paid by WAIOT, and we look for having studies and research and guidelines made up by different experts from various disciplines and various centers across the world. These are some of the papers that we have published, and this is by chance also co-authored by one of our hosts today. We actually have an open special issue on antibiotics that we are editing. And if there is anyone that is listening that would like to join with a paper, there are special rates and discounts for WAIOT members to publish. This is the title, and if you like to contribute, you can contact us at this email. Research, we are funding some grants to special projects, and WAIOT is present in many symposia and meetings around the world since the very beginning. Here are some of them. As you can see, we try to be present in all the parts of the world, and we also have a very strict relationship with the CICOT since the beginning. And these are some of the latest meetings that we have done. This is in Recklinghausen in Germany. And this is the one in combination with CICOT. We will have this year a full day organized by WAIOT and the CICOT Infection Committee in Madrid, Spain, 3 to 5 September. Awards. You have heard a few minutes ago that Professor Agashe did receive an award last year for his research in the field. These awards are intended to the best presentations at our annual Congress, and they reward young and less young doctors and professors in the field. Our annual Congress, we have done our first Congress in 2021. It was done virtually due to the COVID. Then we had our second Congress in Cairo, which was very, very successful, organized by Professor Fadel, who is here, and actually is the incoming president of WAIOT next year. We had our third Congress in Miami, Florida last year, and in a few days we will be in Yokohama, Japan, in a big annual Congress organized by Professor Tsuchiya and Professor Inaba in Yokohama. And next year we will be in Germany in June 5 to 6, where you are all invited to participate. So if you want to join WAIOT, please go on our website and you are welcome. Thank you very much.
Thank you very much, Carlo. It's really exciting that I am also a part of this vibrant society, and I'm sure many of those who are on today watching this will be very much interested in joining WAIOT. Thank you very much.
Thank you.
It's my pleasure Thanks a lot. Now it's my pleasant duty and it's my honor to introduce today's faculty. One minute. Just a minute, please.
Sure, sir. No problem.
Yes. Can you see the screen, please?
Yes, sir.
Yeah. It's my pleasant duty to, it's my pleasure to introduce a dear friend, Professor Mohamed Fadel from Egypt. And he's a professor of orthopedic surgery, Minia University, Egypt, honorary chairman of LRS unit. He has several publications, and you can go on his publications with this ORCID link. And there are several noteworthy achievements. He's an executive board member of EOA, founder and program director of LRS, founder of Assami Arabs, CICOT Computer and Enabling Technologies, WAIOT Vice President, and WOC Vice President. So, welcome, Dr. Mohamed Fadel.
Thanks so much for this generous presentation for me. Actually, I am honored and pleased to be among you, dear friends and colleagues. It is a chance to interchange our ideas as we used to do this every now and then, and honored to be here in one of the most beneficial meeting with Bombay Orthopedic Association, and happy to meet Dr. Mehta and our colleagues. And thanks for Vikas again. May you stop share to start sharing the mine?
Yes, I will stop share.
Or I can.
I think meanwhile, I think I will introduce all the faculty, and then
okay.
you can
Thank
share.
You. Okay, thank you.
So the next talk will be by Dr. Carlo Romano, who is the consultant in orthopedic surgery and co-founder and secretary general of WAIOT. He's a past president of European Society. He's a co-founder and past president of Italian Study Group on Osteoarticular Infections. And he is the founder and owner of Romano Institute and Romano Global Consultancy, Albania, and founder and past director of Center of Reconstructive Surgery and Osteoarticular Infections. So, welcome Dr. Carlo Romano. Thami Benzakour, the past president of WAIOT and a very dear friend. Welcome, Dr. Thami. He's associated with several organizations, has multiple publications. He was a president of CICOT. He was a past president of WAIOT. He's member of honor of Moroccan Orthopedic Society. He's a member of honor of French Orthopedic Society, member of AO SMENA chairpersons and AO Spine, and CICOT Distinguished Member 2022. Welcome, Dr. Thami.
Sorry, there is an error on the map of my country, but...
Is it? I'm sorry.
So, okay, let's go. We'll talk about this later.
Okay. Dr. Chingiz from Azerbaijan. He's a professor, and you can see his publications on ORCID address. He has several prestigious positions. He's a CICOT Research Award, Basic Sciences at Montreal on 13th October 2018. Welcome, Dr. Chingiz. And last but not the least, talk would be given by Dr. Heinz Winkler. He's practicing at Osteo Center in Vienna. He has 25 peer-reviewed articles on bone and joint infection. He is a board member of WAIOT. He is a past president of European Bone and Joint Infection Society. He is a founding editor-in-chief of Journal and Bone and Joint Infection. Welcome, Dr. Winkler. And with that, let me stop sharing and let me invite our first speaker, Dr. Mohamed Fadel. Thank you very much. Will you please share your presentation, Dr. Fadel?
Thank you so much for this introduction for me and for our colleagues, and I am honored to start with you sharing my sample presentation. I hope it is of value for especially our colleagues who are starting their young residency. I hope now it is clear.
Yes, can you make it full screen, please?
Okay. Is it now full screen? Thank you.
Yes, sir.
Management of infected. Thank you. Management of infected foot ulcer. This is our topic this nice afternoon or evening for our colleagues in Mumbai. I am Mohamed Fadel, professor of orthopedic surgery, Menon University Hospital, affiliated to few national and international associations. One of my lovely one is the Egyptian Sports Association, as well as WAIOT. And honored to be with you among these elegant speakers and also elegant Mumbai Orthopedic Association. Thank you for exhaustive preparation and organization long time ago. This is River Nile, while our University Hospital lies on this border. The topic is how to manage this serious and bad condition to be, to some extent, normal like this. It is not easier to do that, but it is easier more to keep this one of the diabetic foot and ankle or Charcot patient to be away of these serious last complications. But we have no time for this today. Today we'll talk about how to convert this to normal or nearly normal one. It is wise in such cases to ask consultation from microvascular surgeons, plastic surgeons, pediatric, internal medicine, endocrine, and many other, such as wound care management. But it was nothing if we have no team awareness of doing this and waiting for others' decisions make the problem waiting too much and maybe end by amputation. So we are trying in many instances to be aware that orthopedic surgeon should keep himself aware of all the basic science of this problem by having data or knowledge about the etiology, pathology, pathogenesis, clinical presentation, clinical assessment, radiological, laboratory, and many numerous classifications and all modalities of management to be in his mind before doing caring of these Charcot joints, because Charcot is a complication of diabetes, which is all over the world propagating, and Charcot itself has also many complications. So looking for this should have some data about some flow charts, which is beneficial, about diabetic neuropathy, about the pathophysiology and the pathogenesis and the development and the progression of the Charcot foot, some flow charts about management, diabetic foot disorders, some publications which help us too much, also the care of diabetic foot ulcers and some comprehensive papers, such as that one of Ruskov. The presentation may come in an acute or a chronic one. Our patient this night is not lucky to come in acute to keep him offloading. This will keep this in healthy condition and some surgical management technique for sharp joint. So he is not lucky also to come after acute in this condition. He came too late after having this deformity to walk on it to have this ulcer later. So this bad sequence of any case in this matter. So our case is a 38-year-old male, type 1 diabetes, complaining of foot ulcer more than 6 months, but he had a past history of deformity 2 years ago. He had a rocker bottom deformity 2 years, walking on it, continuous walking on this rocker bottom foot. It resulted in slowly propagation of an ulcer, which take off the soft tissue and the subcutaneous soft tissue and even the plantar soft tissue, and going down for the bone to result in osteomyelitis. So looking for a case such this, it is not easy to go with it, and looking for it is a need for all data. We should have an investigation doing some of them, and the radiological investigation also. We may go for even 3D reconstruction to define our condition, such as this is the area of rocker bottom, as we see amalgamated bone and the deformed osteoporotic bone. To have also this may give us not about the condition of the midfoot. Our kids have a laboratory investigation not conclusive. Hemoglobin A1C is 8, CBC is RC reactive protein not conclusive. Duplex was normal. So the problem is that we have a midfoot Charcot severe ulcer with deformity and infection. We return to ourselves to solve the problem by ourselves, and no way for dealing with it by the non-surgical modalities. Also, we should go strenuously and going courageously for surgical interference and aiming to combat infection and osteomyelitis, correction and the maintenance of the deformity after correction, and the restoration of the dynamic muscles with this technique. Simply, we use Alizadeh-assisted Charcot midfoot management in large plantar foot ulcer, especially in diabetic patients, aiming to this radiological appearance to correct it. First, we will start in some cases with gastrocnemius recession to correct the inclination of the calcaneus, and aiming to do debridement for all these amalgamation of bone and infection subcutaneous tissue infected, and this some osteotomy to correct and realign and have another foot arch, or at even a plantar without rocker bottom affection, realignment of this bone with some internal fixation tools, and all over it apply Alizadeh. So we will try to correct this bone to the normal one as we can. Looking for the practical and the operating room, resection of the tendon Achilles, here medial side incision, as we do exostectomy, realignment, and we can look here for these screws to help the stabilization of the alignment and the early removal of the apparatus of the Alizadeh. So the Alizadeh correct and safeguard against return and support the internal fixation. As we know, the osteoporotic bone will not keep the internal fixation alive for a long time. So we use Alizadeh to preserve the corrections that we have and the maintenance of the correction, stabilization, and the keeping alignment, and avoiding the complication of relying upon the internal fixation only. Also give us a chance to have wood burning early and prevent ulceration of the skin and avoiding complications. So looking for this post 1 month post-operatively, as we see here, no need for any plastic or any coverage or any sort of interest doing something for the the ulcer here. It is by offloading by the apparatus. Now it is improving by itself. This is the X-ray, as we see here. Also the X-ray, and after removal of the apparatus, here's the soft tissue how it is now. And this is prefabricated pneumatic walking brace after removal of the apparatus. And here now we have a stable plantar grade foot without recurrence of ulceration. 1 year later on, standing patient, satisfied normal walking without assistance and no recurrence of deformity. So we are in need for not hindering the patient by wound care management, such a case, or doing orthoplastic importance and management procedure without the important thing of aggressive courageous debridement of the skin, soft tissue, and bone, and the cleaning this area, application of relaxation and overhead Alizadeh to have outcome of a very acceptable reconstructive case and paving the way to have this nice plantigrade food. Thank you.
Thank you very much, Dr. Mohamed Fadel. A fantastic treatment for a very, very difficult situation. My question is, the debridement and osteotomy, are they done at the same sitting?
I hope that I keep time.
You hear me?
Yes.
My question is,
yes.
Debridement
Yes.
and osteotomy, are they done at the same sitting, or first you would do debridement and then at a later
As I
date?
understand, because the internet is fluctuating, is that in the same session, yes, yes, dear friend, yes, in the same session, optimization of the optimization of the patient as a whole. This is the first important thing.
Okay.
Because it is not an urgent to do it in unacceptable general conditions of the patient. This is one. Then optimization of the area itself. Optimization of the area itself, if we wait for what is long the time we will keep the patient, we will have no improvement by himself, because it is deeply seated and he take 2 years beforehand with general surgery, with orthopedic surgeon. He is not acquainted by the deep of the condition, not in his mind that any ulcer, deeply seated ulcer and wide ulcer in those Charcot ulcers, amenable 3 times folder odds to have osteomyelitis. So he should rely upon aggressive debridement. And why is debridement? We couldn't say that he will remove all the bulk of the rocker-bottom, because he, after resection of the tendon Achilles, the inclination of the calcaneus, which one of the main concern of rocker-bottom, it will be released and improving the condition of the calcaneus and help us in shaping the arch of the foot. So we can say that we help removal of the rocker-bottom that are working on it. Also removal of the soft tissue, removal of exostosis and hypertrophic soft tissue and the bone in this plantar surface area will create a smooth, and we can say if we haven't good arch for the foot, at least we have a plantar, not rocker-bottom. And keeping this as a plantigrade will help us closure of the skin without any suturing. And later on, we just need to keep this continuously for a reasonable time. At that time, we remove Alizadeh because we couldn't do it for forever. And we have now internal fixation, which is capable of continuous working with fabricated sources. But in the session, we do all of the interference. As we know, we all-in-one. We try that this all-in-one save time, and the patient will not even general condition improved to that one of the healthy one ever. So we are going for our best to do it in one session for him.
Thank you very much. Anyone has any questions, would like any point to be clarified? If there are no questions,
excuse me. Yes, I have
yes,
one
please.
question.
Yes, please.
So you did the internal fixation with the screw in just the same session where you did the debridement?
Yes.
It is not dangerous to have infection of the
Yes.
screw?
Yes.
Okay, good.
Okay,
So
yes.
Fantastic result.
The infection, yes, yes, probable to do that, and probable to have infection if we are not doing good debridement. Probable to have this, but this depends on the experience of debridement, the good debridement that we are trying to do it, and keeping in mind that the screws not correcting but maintain the correct positions that we have. And actually the key of success, in my opinion, and I think many, is to get release of the tendon Achilles, because tendon Achilles usually keeps the inclination of the calcaneus.
Exactly.
This push the midfoot to be also rocker bottom. So after releasing it, it will help to many extent to solve the problem. So exostectomy also remove some extra bone which is not needed, and maybe resulted in some raw area of healthy bone to be united later on. Although we are relying upon, as we know all, to fibrous union, not to have a rigid, solid bone-to-bone union. And the stability is much more dynamic and muscle balance more than to be a bone union, bone-to-bone union.
Thank you very much. May I now request Dr. Carlo to present a case titled "When Complications in Young Patients Pose Big Dilemmas." Presentation by Dr. Carlo, and the panelist would be Dr. Rujuta Mehta.
Okay, thank you. So this is the case of a young woman, and I think it's interesting for us to look at possibilities that we can follow to treat even very challenging situations. So this is a young woman, only 27 years, who suffered a polytrauma with this complex fracture of the proximal third of the femur that was treated initially with this long gamma nail and cerclage. And here we are 18 months after trauma with a non-union. She is painful and she has got this non-union. She's not able to walk and she's asking something to do. So what to do in this situation? We have different options: just to wait or renail, eventually plus bone grafts. We can change the synthesis with a plate, or we can use an external fixator, or maybe a joint prosthesis, or even a mega implant. So at that time, one of our colleagues in Italy performed this solution. So he decided in agreement with the patient to go for a mega implant. And he implanted this cementless mega prosthesis. He also performed some intraoperative swab that was negative, no growth. And here we are 24 months after trauma. This is the situation. The problem is that in the meanwhile, the patient suffered two dislocations. They were managed with a closed reduction, but 36 months from trauma and 12 months from implant, she developed pain, swelling around the thigh, elevated CRP and erythrosedimentation rate, positive sonography. So the suspect was that she got an infection, a delayed infection or late infection. But cultural examination at aspiration was negative. Here is the X-ray. It seems that the implant is still well fixed. So the doctors decided to go for a leukocyte bone scan to see if there was an infection around the implant. And what it turns out is that there was a spot that you can see here around the prosthesis, mainly in the extramedullary part of the implant. This is the description of the nuclear medicine, who states that in late images, a focal accumulation is detected in the middle third of the right femur, expression of a small septic collection. So we have positive markers of phlogosis, of inflammation, pain, swelling, and a positive leukocyte bone scan. So what we can do with these, let's say, 28 or 29 young girl? We can wait. We can go for debridement and irrigation, maybe, trying to save the implant, or a one stage, or two stage, or a Gilderstone. What would you do, Heinz?
Well, thank you that you asked me. Because I think you already know what we will do. Of course, in our center, we only do one stage exchanges. However, of course, this is quite, how to say, not so easy case. We had several of those, and in this case, of course, we will remove the whole prosthesis, make a radical debridement, clean everything as thoroughly as possible, intensive jet lavage, several liters of saline. And after that, we try to do a reconstruction of the proximal femur as good as possible. This is not so very easy, but we try to do it. We use our antibiotic impregnated allograft bone. And in this case, it will be necessary to do some additional fixation that can be done with fibrin glue in the proximal part. And of course, then we put in an uncemented prosthesis, modular prosthesis, quite a normal one, nothing custom made or whatever, you can do that quite nicely with one of those revision prostheses. At the acetabular side, it's quite straightforward. I think there are no big defects. You also put some impregnated bone graft and make a new cup. And I'm not sure, is this already double mobility cup? At any rate, we would use a double mobility cup in this case and hope no further dislocations would appear.
Well, this is what we found at surgery. She had this appearance. You find this kind of material, which can be sometimes found in mega implants. Especially if you look at oncological cases, you can see this kind of reaction. And this may be a sign of some mechanical reaction of the soft tissues to the implant. The implant, as you can see, look very well fixed. There was no osteolysis around the implant. So we tried to remove the implant, but it was very well fixed. And the same was at the cup, where we could find this appearance behind the plastic insert, which can be seen sometimes. So we removed the modular part of the prosthesis, all of them. We exchanged the prosthesis, but only the modular part of the implant, and put a silver-coated one. And we used a hydrogel antibiotic-loaded coating, and we reconstruct, but without removing the intramedullary part of the prosthesis. Afterwards, we treated the patient with levofloxacin and rifampicin for 12 weeks, and antibiofilm processing of intraoperative explanted biomaterial grew a oxacillin-resistant Staphylococcus epidermidis, as you can see here. So it was for sure an infection. This was sensitive, however, to all the antibiotics that we administered. And here we are 24 months after surgery. In the meanwhile, the patient get married. This is the data. And here we are 10 years after surgery. She got pregnant. She had 2 babies. She was doing very, very well 10 years after surgery. 13 years after surgery, last January, after a trauma, she complained about a swelling. This is the sonography. This is the MRI. And this is the consultation she had, because she lives in the center of Italy, with the disease specialist that reports all the inflammatory signs are negative. She only has this swelling. In my opinion, it is not even worth doing a joint aspiration. What do we do now? What do we do? 13 years after debridement and irrigation. This is the leukocyte bone scan that she has done 1 month ago, 2 months ago. Nearly everything is cleaned except for a small spot here in the posterior aspect of the implant, but nothing around the bone. So my suggestion is let's wait and see. So the lessons that I learned from this case is that actually we don't have a real way to define the extent of an infection. But nuclear imaging and visual inspection at surgery, especially when you have a very well fixed uncemented implant, should prompt you to think maybe this implant can be saved. Because also for bacteria, it is not so easy every time to colonize all the implant. The second thing is to take in your mind is the type A host, like this woman, they maybe can still have our debridement, some small grade, low grade infection, but this can stay in balance for many, many years, maybe 10, 15 years. So if we are the possibility of doing an exchange of modular parts and keeping the implant without doing the big war or the big surgery, it can be a good option for some cases. And protected surface or coatings may sometimes help you to clear or to reduce very much the bacteria. And the last remark is, take in mind that we can have sterile seroma in especially in mega implants, but also in primary implants sometimes. So first of all, think that you can have also swelling that is sterile. Second, if you go for surgery, try to use antibiofilm techniques to finally understand if there was some bacteria, because sometimes even aspiration or traditional cultural techniques may become negative, but there are bacteria inside. Thank you.
Very interesting case, Dr. Carlo. Couple of questions from my side, and of course, I would want any of our esteemed faculty also to put up their hands and ask if, to make any points that I may have missed. Would this have been really an infection because of the cement used that you think? Does it make it more predisposed to a biofilm and therefore more difficult to treat?
I think this case may have been an infection since the beginning. Maybe also the non-union was infected by a low-grade infection, and they only took swabs, but swabs are not enough to identify a low-grade infection. So this is first thing we have to keep in mind. So probably in this specific case, as far as I think, they have they have resected the bone, so they have removed the majority of the bacteria. The field was somewhat contaminated, and the contamination went but on the extramedullary part of the prosthesis. This is why we could save this implant. And this is why also now the patient has no pain, because the implant is very well fixed. So, in my opinion, not all the infections, the implant-related infections are the same. We must distinguish. And unfortunately, we don't have very reliable imaging techniques, even if they are studying. I have been in Rome last year in December, and there was Palestro. There were very important nuclear imaging specialists from around the world. They are studying specific markers for infection. When we will have this, we can do a very step forward. But in a case like this, the pathogenesis of the infection probably was at the time of the first step, the treatment of the non-union, of the fracture. At the non-union, they make a large resection. The implant was contaminated in the extramedullary part. So our possibility to do a modular exchange parts was successful in saving the implant.
And another question I would like to ask is that small collection which is still lingering there, would just simple plain IV antibiotics, assuming that this is MRSA again, would that help in any way?
If I had to treat this patient, I would always go surgery and medical treatment, because I think that only suppressive treatment with antibiotics, if I think that there is still an infection in that part, it is better that I go with the surgery, which is a relatively small surgery, and I increase very much the chance that a conservative treatment is successful for another 10 or 20 years. If I only administer antibiotics, the chance that I make this collection sterile is relatively low, and I can induce resistance. And so I think that at the moment we are waiting and see in accordance with the patient, but the next step is that we go, and if we decide to operate, we do a treatment that is combined surgical and medical.
Any of the other faculty would like to ask any questions here? Dr. Agashe, sir?
Oh, no, I'm fine. Fantastic case and great follow-up.
Thank you.
Great follow-up.
Thank
Okay.
you.
Can I request Dr. Carlo to unshare his presentation so that I can load up the presentation for Dr. Thami? Just give me a minute.
Just a comment with Dr. Carlo, if possible.
Sure.
I think the physician was obliged to remove this long sector of the bone and to make mega process. I think that if it is not, I think it could be reconstructed by other means, because mega process post-infection of the traumatic condition, it is not usual, I think.
Yes, but to do a mega implant in a girl of 27 years is highly discussed. Personally, I would not have done, because I think it is too much. Yes. It is too much for a girl, because I think a case like this, you could do a renailing, maybe using the allografts of our friend Heinz. You can save the joint that is completely healthy. So it was an over-treatment to do a mega implant.
Right.
Absolutely. It is important that we say to those who are listening to us, this is an extreme case, but don't take this solution as mega implants for this kind of patients unless they are maybe very old or that you don't have other chance. But I think it was absolutely an overtreatment.
Actually,
Absolutely.
yeah, it be reserved for management of cases of chondrosarcoma,
Yeah, of course.
sarcoma,
Of course.
any post tumorous complications.
Yes, but
to
in
use this.
Italy and in Europe, there is a push, especially also from the industry, but also from some surgeons, to expand the indication of mega implants to non-unions, to post-trauma patients, which in some cases can be good, a good solution. But in this case, I think it was an over-treatment.
Thank you so much for this comment. It is so serious,
Absolutely.
especially for our community, such as Egypt, India.
Thank you for pointing out this issue.
Thank you. It is reserved for oncological conditions.
Excuse me,
I want
friends.
to underline Carlo's statement. I want to underline that because it definitely is an overtreatment, especially when the hip is without any damage, the hip joint itself. And it could easily be done, especially in such a young patient, when you do a renailing, as you suggested, and just make a radical debridement, only remove the bone which is dead. And I think most of the bone that you showed in the first case was not dead at all. They were still alive. That could be kept, and only the defects to be supplied with some allograft. In our case, of course, with the antibiotic impregnated allograft. And I'm rather sure in this case you will have an excellent result. In my presentation, I will bring some comparable case that also you can see that this is really the method of choice and not to make an overtreatment with expensive prostheses of that kind, which of course are favored by the industry, out of some understandable reasons.
Can I share Dr. Thami's presentation now?
Please.
You can start, Dr. Thami.
Yes.
Will you make it full screen?
Okay. Full screen. So like this. Is that okay for you?
I've done that. Yes. You can start speaking and just tell me to change the slide when you've.
Excellent. So I have no disclosures. Okay, go ahead, please. Slide. So our patient, first of all, I would like to thank so much BOS and WAIOT for their kind invitation to let me talk about case presentation for spine problem. And the case presentation is about a patient, 67 years old female, who is diabetic, smoker, with pulmonary fibrosis and other problems. And she had an intensive cough, which was followed by a spontaneous mild T6 osteoporotic fracture. So the fracture was very slightly kyphosed at the beginning. Yes. And the problem at that time to the people, to the doctors who were dealing with, was to decide whatever they have to do orthopedic treatment, augmentation, fixation, or abstention. But following the AO spine classification recommendation, they recommended a corset. Slide. At D45, after the corset prescription, the patient was checked in her initial hospital for intense pain. but she had a poor compliance with the wearing of the corset, since the corset was not worn, and back please. The patient presented severe cognitive disorders and almost permanent need for nursing care at home. Slide, please. The patient's status was reconsidered at that time in view of her heavy history. An option of T6 cementoplasty was advised and an appointment taken in interventional radiology. However, slide, please. At the 6 months, the vertebroplasty not having been performed, the patient returned with incomplete paraplegia, worsening of the fracture in kyphosis and spinal cord compression. Slide, please. The worsening of kyphosis was accompanied by a spinal cord compression, as you can see. Slide. So, at this time, how to treat these complications? Orthopedic, augmentation, laminectomy, surgery, fixation, or abstention. Slide. So this is what they have done. T6, T7, T6, T5, T6, laminectomies, and T3, T9 fixation. This was, let's say, acceptable, okay, for this case. However, slide. Unfortunately, after 5 weeks, when the patient was transferred to our center, she presented a disabling back pain plus fever, inflammatory scar with disunion, biological inflammatory syndrome with staph in blood and coli in the urines. Slide, please. So, to the left, you have the first surgery, and then to the right, you have the complication with the arrows, the yellow arrows, showing that there is a disassembly of the implant's lower part due mainly to infection, osteoporosis, etc. Slide. So classically, they gave her antibiotics protocol based on levofloxacin, cefazolin, vancomycin powder during surgery, and then she had levofloxacin and rifampicin later on for 5 weeks. Sorry, slide. So what was done is an immediate surgical revision in our center with debridement, excision, cleaning, classically, removal of T7, T8 screws, extension of the arthrodesis by adding T9-10 screws, strengthening of the fixation by T7, T8, T10 links, and also suction on drains. This was our revision. Hopefully, satisfyingly, if I could say, after 1 week, we could ask our plastician to take care of her coverage. He made this keystone flap, which went quite well. Slide, please. Mehta. Dr. Mehta.
Yes, one more? Or
Yeah.
this one?
No, not this one. No, not this one. This one, yes. At 2 months now. It's quite satisfying aspect after coverage. And then finally, this one, the next, please. This one, it is at 2 years. This is the final aspect, if I could say. Slide, please. So, since we had at the beginning a few minutes more for presentation. Slide back, please. I'm going to just report a few articles from the literature, recent literature. This one is a WAIOT article about diagnosis of infection and treatment. Diagnosis is based mainly on blood workup, CT needle cultures, histology, and imaging. However, it's good to remind that sensitivity and specificity of CT-guided needle biopsy is, let's say, quite low, 50%. I think it's the same in other parts of the body. We also come back to the titanium implants, which are the optimal hardware due to the less biofilm formation. And a recommendation of this article: in cases of gross instability, neurological deficits, failure of conservative treatment, spinal abscess, severe sepsis are for surgical treatment. Surgical treatment is required. Slide, please. This other article of WAIOT also, 3 years ago, it was in association with other authors from CCOT, which conclude that the present editorial article discusses the multidisciplinary approach for managing bone and joint infection worldwide, and it also explores the controversies and practices in terms of training, expertise, research, prevention, and management of musculoskeletal infection. Finally, it acknowledges what orthopedics can obtain from specialists of infection and to provide the best care in order to provide the best care for patients. Slide, please. This article 2023 by Bavuk Gag, our friend Bavuk Gag, with great surgeon from India, even though he is quite young. And he had this editorial for a special issue of the NAS journal, the new NAS journal, North American Spine Society. And in his article, he mentioned some information I would like to share with you, saying that despite improvement in public hygiene and socioeconomic conditions, the incidence of spinal infections across the world continues to be on the rise. So we have to give all our attention to the management, prevention of infection of orthopedics worldwide, and we need support of many other associations, many the most important associations, either Asiatic, European, American, African, and others. He also mentioned, Bavuk also mentioned that the potential of metagenomic next generation sequencing is the next big step in laboratory diagnostics of spinal infections. And this has to be also indicated. Slide, please. Finally, before the final, another article this year by an important team in China, concluding that there is an available evidence support that the effectiveness of negative pressure wound therapy in treating deep SSI following spinal surgery, suggesting its clinical utility. So don't forget negative pressure wound therapy. However, further studies are needed to compare NPWT with other treatment options for SSI's management. Slide. Another article, 2023, just to give the updates of the on spinal infections, postoperative spinal infections. This article concludes that the study supports the use of negative pressure in the treatment of a primary spinal infection and indicates that it has a notably better short-term clinical effect than conventional surgery. Additionally, its mid-term cure rate and recurrence rate are more desirable than those of conventional treatment. Slide, please. So this is our take-home message. First of all, as you see, our case began with an orthopedic, simple orthopedic issue, and it finished with a big infection. So we can say that both orthopedic and surgical spinal options may lead to complications. So the surgeon should prevent infection, considering the risk factors. He should note that early diagnosis and immediate revision are of utmost importance. He should also apply gold standard treatment, as has been said by other speakers, antibiotics, antiseptics, dissection, irrigation, etc. And the surgeon should consider removing or changing implants if necessary, but when is it necessary? Finally, the surgeon should adapt treatment options, orthopedic or surgery, avoiding complications if possible. Thank you. Slide, please. Thank you so much. And sorry for the delay.
Open for discussion now. And Dr. Gautam Zaveri is here, so he's a spine surgeon. He can best discuss this.
Excellent.
I think it was a wonderfully presented case. Congratulations, Professor Benzakour. I think all the principles of treatment of an infection in the spine were followed here. Appropriate change of implant, appropriate antibiotics. But my question, Professor Benzakour, is, we are big believers in the negative pressure wound therapy. It has worked very effectively for us. What is your experience personally on that?
Thank you very much for your kind words. You are a very respectable man. You're very well known worldwide. And thank you for this question. In fact, we are beginning the experience with this technique, this new technique. And it has been said and encouraged. And but however, we don't have final results saying that it is effective, efficient, 100%. It is not even 90%.
Right. So what we have found is that when we use a negative pressure wound therapy, our need for flaps, skin grafts, etc. has reduced considerably, because with the negative pressure wound therapy, it sucks off the edema fluid and the wound shrinks very dramatically. I don't know what is the evidence, whether there is 100% evidence on the use of infection, but practically I can say that we have used it in more than 45 to 50 cases of spinal infections, and it has worked wonderfully for us. Usually we start off by applying the WAC, and we retain it for the first 5 or 6 days, and then we keep on changing the WAC every 5 or 6 days till we are happy with the wound condition. Usually it takes about 2 to 3 weeks. And after 3 weeks, we are able to actually close the wound secondarily over a drain, and it works quite brilliantly for us. It has done wonderful job.
I agree with you. There is no miraculous solution for these kinds of cases, but experience will talk with time. Your experience will teach us some lessons, and we are ready to follow your experience.
Thank you, sir.
Excuse me, about negative pressure. May I say something?
Yes, sir. Go ahead.
And lower limb, we used it frequently in leg and femur problems, soft tissue loss, and it is effective actually. But some requirement is that it is not possible to have good results in cases of open joints or on bone directly. It should have a bed clean, not infected, because some people think that they are disinfecting. It is not disinfecting. We should clean. This is our experience about leg and the femur and even musculoskeletal other than the spine, as we are not dealing with it. So we have a very good results from it, and we have a good clear granulation tissue, and so we can get rid of full flap or full thickness flap, and we can use split thickness skin grafting in many conditions if possible. So it is good and valuable for musculoskeletal infection and soft tissue loss. Not it is not experienced in the spine.
Agree.
Thank you.
Thank you.
I think I think that the limit of negative pressure is that you cannot use, in my opinion, in my experience, when you have exposed bone or exposed implants. So it is good, maybe it is good, but in patients where you have good vascularization, which is something that often in the spine is there, so it may work. But you should not, in my opinion, have exposed implants or bone.
Yes.
After 2 or 3 days, the sponge of the VAC has been found having biofilms and bacteria, so it gets colonized as well.
Yes.
Yes.
So
Yes.
if it is applied on a living tissue, well vascularized, it may promote healing of tissues. But if you
Yeah.
try to do for exposed bone or implants, it may be only you are buying a time with your patient, but it's very difficult that you can achieve really sterilization and the healing of an infection.
Yes.
Oh,
Thank you very much. May I request Dr. Chingiz to share his presentation on osteomyelitis of the lesser trochanter.
Excuse me, do you see my presentation?
No, we don't.
Why? Why
You
not?
did it before. You did it before.
No, he didn't.
Why not? I don't
Will
understand.
you open your presentation on the screen and then go to screen share and click? Please open your presentation.
Yes, I open it.
Now, please go to the green icon, share at the bottom.
On your screen, on your Zoom screen.
Excuse me.
Your Zoom screen, you have a bar down the screen.
Where is the screen?
Yes, move the cursor on the screen, because it is disappear every now and then. You move the cursor to have it to appear.
Where is
Okay,
where is I don't know.
move the cursor, move the mouse, move the mouse by your hand until you found this. There is a chain of icons below.
Okay,
Have you found it?
meanwhile, may I request Dr. Okay, meanwhile, may I request Dr. Winkler to share his presentation so that we don't, we save time.
Send it for
Yeah.
me, Dr. Jenkins. Send it for me, please.
Yes,
If it is,
now I open my presentation. What can I do?
send that for me.
So can you see my presentation now?
Yes, please. Fantastic.
Yes, so I can continue now.
Please.
Thank you for this invitation to your prestigious Bombay Institute. I'm very glad that we can share some out-of-the-box cases and procedures now together with you. Because we all know that bone and joint infections are quite difficult to solve, and the reason why was found out by this gentleman here, by Bill Costerton, who found out that most of the bacteria do not live in the seemingly well-known planktonic form where they swirl around, but most of them, more than 90%, more than 99%, live in habitats of where they are very safe from every influence from outside, called the biofilms. And it has also been Bill who suggested that this biofilm theory at that time should lead us orthopedic surgeons. And we have followed this advice, and we have found several features that need to be seen. When we all know that to solve orthopedic infection, you need a radical debridement, and also you need some conventional antibiosis. With this, you can remove the predominant amount of bacterial load. You can eliminate the planktonic bacteria and even disrupt some parts of the biofilm. However, it is not possible to remove the microscopic remnants inside the infected site. And these remaining phenotypes, they require much higher antibiotic concentrations to be eliminated. This concentration is called the minimum biofilm eradicating concentration, MBEC. And because this is very difficult to be reached, most of the procedures in this case concentrate on 2 or even more interventions so that they can eliminate the infection. Of course, this is a big burden both for the patient, for the clinic, for the surgeon, all of them. And it's only because you cannot combat this concentration eliminating biofilm. And this you can see here that there's a big difference. And then everybody knows about the MIC, the inhibition concentration, which in this case, that is depicted here, is quite normal. You need very low concentrations of antibiotics. Many of them are here listed, and to eliminate the planktonic form. However, what happens as soon as this Staphylococcus hides itself inside a biofilm, the concentrations that you have here are several thousand times higher to eliminate the staphylococci. And these concentrations, of course, never can be reached by systemic antibiotic therapy. This is absolutely impossible. quite advantageous. What you can see is still with vancomycin, which is quite a nice antibiotic against biofilm. However, still much too high concentrations required. So we have we have found some basic requirements for eliminating these biofilm-associated infections. First of all, I always underline that you have to detect the bacterial habitat as exactly as possible. I come back also to this case that has been shown by Carlo before, when he did not remove the well-fixed part of the stem. Obviously, this one was not infected, so it may be that it can be left in situ, as was also done with success by Carlo. Of course, we all know about the debridement. We should also disrupt the biofilms as much as possible. And another thing that comes into the game is the dead space management. Whenever you remove infected tissue, you have a dead space that needs to be filled by something. And otherwise, you have a possible colonization again with the remaining bacteria. Decontamination is the part which so far was still under discussion, because how can you do it? And in our idea, it is only possible to decontaminate the site by using a local antimicrobial chemotherapy. And what should you take? We should choose an antibiotic which has a poor tissue penetration so that it cannot be swept away. And of course, it also requires low cytotoxicity, so not to inhibit the development of osteoblasts and other required cells for the reconstruction. Just the other way around, for systemic treatment, we need good tissue penetration and good tolerability, which is the most important thing. And so you should choose very carefully. There are different options for both. What we have done also, we want to reconstruct the bone. So we have cleaned cancellous bones like here, and when you clean it, you have a very high storage capability. And with on the matrix, which is biologically inert, and it seems to be an ideal carrier, we have then impregnated on a special technique this cancellous bone with vancomycin and or with topamycin, and we got excellent kinetics where these antibiotics were expressed from the carrier, which are much more efficient than, for example, antibiotic-loaded bone cement. You can have altogether 1,000 times higher concentration for several days. So this is the product that we have developed out of that. It is on the market since 2010. These special products can protect the implant and decontaminate site, and it also takes care of the regeneration of bone stock. So we believe that only by using such local antimicrobial devices, it makes a single stage treatment feasible. Otherwise, we would be scared to go for that. Of course, we do everything in one operation, but we use 3 steps. First of all, we do the rough reconstruction and debridement. Then we change our gowns, and only in a 3rd step, we do the reconstruction with clean instruments, and we do corrective impregnation and the bone grafting. Implantation of our devices into the reconstructed area is always uncemented, and so we can primarily close all the wounds. So this is an example of a young man, 35 years old. He had an infected non-unit. 3 revisions were without success. He had a draining sinus, and obviously a rather big defect here in this area of the former fracture in the culture. We found the methicillin-resistant staph epidermidis. Of course, we did a one-stage procedure, which means we remove the nail, we make a local sequestrectomy, then we do bone grafting with our impregnated bone grafts and do another nail, fix everything with a new nail, in this case, a thicker one. We never sacrifice vascularized bone, never. So, but of course, dead bone, which is not to be removed. So to find the differentiation, we use such burrs like this, and we trim down the sclerotic bone until we can reach so bleeding surfaces, like you can see here, the so-called paprika sign, and then we stop the debridement and leave everything as it is. So 3 months post-operative in the follow-up, the patient is absolutely pain-free, without any sign of infections and fully weight-bearing. Of course, the non-unit is not yet completely healed, and you can still see here the grafted areas with our osteomyces. And after 1 year, we do a so-called dynamization. It means that we only remove the proximal part of the nail. At that time, there was also no sign of infection, and the patient was fully in working conditions. This is the result after 4 years. You can see that the non-union after 4 years has completely healed, and there is no further problem. And after 7 years, the patient wanted to get rid of the nail. So we did it, and we could even remove the nail. And you can see that the whole situation has healed as if nothing had happened. Another case is an infected hip of a female of 64 years. She had a mixture of gram-positive bacteria, some of them methicillin resistant. And you see here the huge defect, especially on the acetabular side. In this case, we put the impregnated cancellous bone here into the defect of the acetabulum, and we do some kind of an impaction grafting using special devices until we get the firm bed for a new implant. In this case, you can see here the reconstructed area, and we insert then an uncemented implant into that. And this is the final top that we did. The post-operative X-ray still is the allograft is still nicely visible. After 2 years, you can still see some parts of the allograft not vascularized, but there is already a completely closed area. So the defect is at least contained at 2 years. And after 8 years, everything is fully reconstructed. And also there is a good situation on the exchanged stems. Okay, so we say that this is antibiotic impregnated allografts. We can do single stage supply of infected total joint replacement and also of non-unions. It results in a short treatment with improved functional results, reduced systemic antibiotics. Nobody gets antibiotics systemically for longer than 4 weeks. This is our limit. We have reduced that more and more. Now we have made 4 weeks systemic treatment in parallel. Even if there should be a failure, which happens in some 10 to 15%, we still have not worse conditions, but improved conditions, while with antibiotic-loaded cement, mostly in case of a failure, the conditions are worse. So anyway, thank you very much for your attention, and we'll be happy to answer any questions.
Thank you, Dr. Winkler. Fantastic cases there. We've heard a lot about your allografts with antibiotic impregnation. So, a couple of questions there. One is, what about the countries where it's not commercially available? Managing these with local antibiotic delivery systems can get challenging. So, do you have any ingenious solutions that we can maybe use your technique and try and get the same antibiotic delivery in the allograft that's available to us? Is there any way of incorporating antibiotics?
I believe you cannot have exactly the same positive results, but of course there are possibilities to come close to it. It took us 10 years of development, of research and development, until finally we could bring this product to the market, which is first of all has some special features that cannot be reached by everybody by itself. It is also a pharmaceutical procedure, and our procedure is, of course, in conformity with all legal applications of Europe. And there are three requirements that make it so effective. The first is that you have really a thorough cleaning of the cancellous bone. In our position, the dead marrow inside the bone is always some obstacle, first in healing and also in eliminating the infection. So bone marrow and everything else must be removed thoroughly, which is done in our case with supercritical carbon dioxide. So all that is left is just the matrix consisting of collagen and minerals, nothing else. So that makes it very inert and also very good for incorporation. And the second is that the antibiotic that you put inside also should have a certain specific kinetics, which means that you need astronomically high concentrations, or that's what they are granting in the first days after implantation, about 1 week, 5 to 6 days. The concentrations are really extremely high. That is what is required to eliminate biofilm remnants, but this cannot be all the time as it is. And after, let's say, 3 to 4 days, the concentrations has to slow down so that you still have sufficient concentrations, however, not such high that they would inhibit the incorporation of the allograft. And so that took us more than 10 years to get this special features altogether.
Thank you. So I think we'll have to wait for the product to be available in our regions to start using it.
Yes, I think it should be feasible. It's not so easy. We have now sent it also to Hong Kong, in the Asian Rim. We have also some surgeons in Malaysia who already use it, but there are not many. I must admit, there are not many yet because it's also not cheap, of course, and but it is steadily increasing. We are quite happy with that.
Thank you. Thank you so much. Hand over to Dr. Agashe to take it over for the next presentation.
Okay. Dr. Chingiz, have you been able to share your presentation? Will you be able to share your presentation? Otherwise, I will start my presentation. Oh, yes. Great. Fantastic.
Chingiz, you should unmute the microphone. Your microphone is muted.
Maharshi, can you unmute Dr. Chingiz?
Maharshi. Anyway, can you call Maharshi, please? Then,
Yes, now I think he's unmuted. Can you start your presentation, please?
May I start it?
Yes, great. Please make it slideshow and then proceed.
I don't understand what is happening.
Just talk. Just talk, Chingiz.
It is working, Chingiz. Go ahead.
We can see your presentation.
Oh. I don't understand what is happening.
Oh, you're not able to. I think you can go to the next slide, please. Can
Yes,
you go to the
please.
next slide? No.
Tuck.
Sir, I'm making a circle on your screen. Please try to press that button. It's a red circle. Look for the red circle.
we can't see that red circle.
I don't understand what is happening.
Maharishi from Ortho TV, can you request control and put the thing on slideshow? Or sir, can you press the F5 button? F5.
I don't have.
What is your problem, Chingiz?
I don't understand what is it. Why?
You don't.
I mean, if you can email the presentation to one of us.
But I can see the presentation.
Yeah, but the slides are not
I can see
moving.
the screen of Chingiz. I think you also can do that.
Do you see my presentation?
You can see the
Yes,
slides.
of course.
It's not moving ahead.
But I don't understand why. What is it? I don't understand what is it.
But go to the next slide, Chingiz. As you
Do you see my presentation? But I understand where is the microphone. Do you listen me? Do you hear me?
Yes.
Okay.
Yes, we can hear you.
May I beginning?
Yeah.
Yes.
Yes,
Go ahead.
Okay. I begin.
Perfect.
Excellent.
Sorry, my friends. Sorry. But I don't understand what is the meaning. Excuse me. May I begin? First
Please.
of all, I would like to thank the management of WAIOT and BOS for giving me the opportunity to speak at this wonderful webinar. I will show a very rare case of chronic hematogenous osteomyelitis of the lesser trachanter and the surgical approach to the lesser trachanter, what I have developed. Case. A 31-year-old woman was admitted with a fistula in the upper third of...
Move the slide. Move the slide.
Okay. With a fistula in the upper third of the right femur.
Next slide, please. Next slide.
Do you see? Next slide.
No.
You get your arrow off the...
Okay. Okay. Do you see next slide?
No.
Don't move. Yes. It is not move.
But now?
No movement.
No, I mean, your arrow is on the something. It says.
There is a first slide. Do you see them?
We see the first slide. Please go to the next slide.
Next slide. Do you see it? Do you see it? Next slide. Oh, what is it? Next slide. Do you see it?
No.
I don't understand. What is it? I don't understand.
Can you click? Can you press on the enter?
Now, do you see it?
Yes.
She reported that the pain, which began suddenly more than 1 year ago with a high level, was treated locally. A skin incision on the lateral side of the femur released pus, but the fistula persisted despite prolonged antibiotic therapy. X-ray and fistulography was performed. Do you see it?
Yes.
In this fistulography, you see that contrast agent is concentrated on the area of the lesser trachanter.
Right.
Diagnosis was made: chronic osteomyelitis of the lesser trachanter of the right femur. But the question arose: what surgical approach can we use to reach the lesser trachanter? So many approaches was to made from the to the tumor in the area of the lesser trachanter. But now in our cases, we must not only resection of lesser trachanter, but made a big necroectomy. You see it. Now we can see a CT scan of the upper of the femur. The readouts indicated the surgical approach to the lesser trochanter between the muscle of excuse me. We began to study schematic CT section of the upper third of the femur. As a result of studying this section, we found that access to the lesser trochanter is possible.
We can't see your, excuse me, we can't see your screen.
Do you see it?
There's a blank slide here. If so, just click to the next slide. There's probably a blank slide there.
Do you see the previous slide?
No.
Oh, la, la, what can I do? But now you can see it?
Yes.
Okay. We began by studying schematic CT section of the upper third of the femur. As a result of studying this section, we found that access to the lesser trochanter, access to the lesser trochanter is possible between the vastus lateralis muscle and the long head of the biceps femoris, this area. I don't understand what is.
No, you're doing good. Absolutely. Please go ahead.
Surgery. Do you see it? Sorry.
Yes, yes.
Following tight packing of the fistula tract with brilliant green and hydrogen peroxide solution, about 11 centimeter skin incision was made along the posterolateral surface of the upper third of the right femur, slightly below to the lesser trochanter. An incision was made through the fascia at the junction of the gluteus maximus muscle and fascia lata direct towards the posterior femoral surface. After the fascia was cut, a space filled with necrotic tissue was found. The fistula continued towards to the lesser trochanter. Then the incision should be made between the muscle vastus lateralis and the long head of the muscle biceps femoris after the limb was internally rotated. A long head of the biceps femoris was bluntly dissected from its insertion site on the femur, and the lesser trochanter was delivered into the wound. This one. Upon exploration, it was noted that tendon of iliopsoas muscle was completely detached from the lesser trochanter. The lesser trochanter was devoid of periosteum and had a rude texture upon palpation. A cavity filled with necrotic tissue stained with brilliant green. Solution was present around it. Necroectomy was carried out. Resection of the lesser trochanter was performed. Examination of a specimen revealed penetration of brilliant green due into the lesser trachanther. Do you see it? After copious washing of the wound with antiseptic, the wound was drained and closed. Yellow arrows indicated fistula scars. The wound was heavy primary. The patient works to full load and no complaints. How many approach we know in the upper third of the femur? Gibson surgical approach. Some after use this incision to approach tumors in the femoral neck and lesser trachanther region. This is our proposed surgical approach to the lesser trachanther. In 1971, Zatsepin and Gamidov in this article show tumors of the lesser trachanther as their surgical treatment, but they use anterior approach. In 1976, Zitnitsky used Gibson surgical approach. Yipin et al. A novel surgical approach, which was the treatment of tumors in the lesser trachanther, but they used anterior medial approach. And his article authors emphasized in their article there no currently surgical approach aimed especially at the lesser trachanther. Adnan Lahar and all use the Ferguson approach in lesser trachanther tumoral surgery. They use the Ferguson approach. This is another approaches, Landlof, lower approaches. But if you know, if you see, all this approach is anterior approach, anterior medial approaches. They after used an anterior medial approach at Ferguson. In osteomyelitis of the lesser trachanther, pus never spread to the anterior region of the skin. It penetrated into the intermuscular spaces along the posterolateral surface, covering the powerful biceps femoris muscle from the outside. Therefore, unlike approaches for tumors in the area of the lesser trachanther, the surgical approaches for osteomyelitis should allow the surgeon to perform adequate necrectomy in soft tissue with the excision of the fistula. In our opinion, this is a fundamental difference between approaches to the lesser trachanther in the tumor process and its osteomyelitis. This case is interesting because the chronic hematogenous osteomyelitis has had a rare location, the lesser trachanther. The posterolateral surgical approach to the lesser trachanther described here has not been previously reported in available literature. This posterolateral approach allows our traumatic access to the lesser trachanther and facilitates the necessary surgical maneuvers. In summary, I would like to say that in my more than 14 years experience, I see only one patient with chronic hematogen osteomyelitis of lesser trachanther. Thank you very much for your attention.
Thank you, thank you.
And excuse me for my some problem with my
No problem.
presentation.
Can you stop sharing so that we can go to the discussion? Dr. Menon?
Yes. Fantastic. I think probably the most unique case of the night. Extremely rare to find an osteomyelitis of the lesser trochanter, exactly what you described in your case, and So one question is, did you find out the bug or the pathogen which was responsible for this infection, and something that resulted in avulsion, literally a tear of the iliopsoas insertion? When that has to be something pretty aggressive and virulent to cause that kind of damage in this area.
Thank you very much for your question. This is only Staphylococcus aureus with this case, and our protocol is to treat antibiotic therapy. It will be 1 week ciprofloxacin by intravenosis by 100 milliliters twice per day. And after 1 week, and after 10 days, ciprofloxacin drugs by 500 milligram twice a day.
All right. Thank you. Thank you so much. Dr. Winkler, I think you're still muted. You have a question there? You're muted. Yeah.
Can you hear me now?
Yes.
Can you hear me? Yeah. I believe there is a rule for septic surgery that, at least in my department, it is always followed without an exception, that when we find a fistulation, and we even can demonstrate the connects by fistulography, then it is a rule that as an access, we always follow the fistulation to the point of the infection. I do not see any reason why we should look for some other approaches, because in this case, when we go by, then we lose the opportunity to make a radical debridement also of the fistulation and all possible abscesses which already have occurred on the way. There are more than you might expect, because the fistulation can also spread in other directions, which are not absolutely always visible by fistulography or MRI. So just to take
Heinz, thank you very much. Thank you very much for the question.
The fistulography as the guiding way to the infection.
Thank you very much. This patient came to our clinic about 17 years ago. This time we haven't CAT and MRI. And in my opinion, the pain, the main rule and the success to treating such patients is careful treatment.
And I believe careful treatment also covers careful examination of all the way from along the fistulation. The training sinus should be explored very thoroughly.
Thank you very much. Careful treatment is careful, clear debridement, resection, and clean debridement, and necroectomy, of course.
Excellent.
Thank you.
Can I share now?
Yes, sir, please. Sir.
Yes, sir.
Can you see my presentation?
Yes, sir.
Okay. So at the outset, thank you BOS and thank you WAIOT for organizing this. And this is a young girl who had a very unusual complication during treatment of non-union tibia. So at the outset, I thank our multi-speciality team So this was a young girl, extremely short-statured, 4 feet 4 inches, and was a walker dependent. She presented She presented with a non-union of 17 years with malposition and a fused ankle. But to top of that all, she had a very poor quality skin. Now you can see these are blisters here, and the skin envelope was very, very poor. It used to break down at least once a week and would discharge pus there. Going to the history, she had a road traffic accident at the. She had bilateral open tibia fractures. Multiple surgical procedures were done, but she was unable to bear weight on the right side. And she presented to us with the expectation of fracture healing and deformity correction. So this is where we are. And we thought the first step would be to achieve a good soft tissue cover. However, with this skin, the local rotation flaps was out of question. The other side also was, the skin was very bad, so we could not think of a cross-leg flap. We thought we might be able to do a microvascular flap, but she was perfused, the leg was perfused only by a single vessel. And therefore, we could not think of a even microvascular flap. So the only option our plastic surgeon thought was a cross thigh flap. And so the plastic surgeon raised a flap from the opposite thigh and attached the leg. This is after excision of the skin. And here you can see a limb position. And I had used external fixator to immobilize and suture this. At about 6 weeks, she had a small sore on the right knee. And at that point, she went back to her native place, more than 1,000 kilometers away. 4 months after this, she came in with a large sore on the knee. You can see this, that's the patella, which is totally necrotic. And there's a quadriceps rupture here. So we have, from a relatively normal skin, now we have a large skin defect. The culture was methicillin-resistant Staphylococcus aureus. We have a tear or rupture of quadriceps. We have necrotic or osteomyelitic patella, as you can see in this X-ray. And the tibial non-union is not yet addressed. Now what should I do? Any opinion? We have a large sore on the patella with necrotic patella, rupture of the quadriceps, and the original non-union is not yet addressed. Any opinion?
How old is she?
She's 27.
Now.
But how is the skin of the leg now?
That is better.
So the leg skin is okay.
That's right. The skin is good.
In the right leg, you succeed in covering the skin or not?
Yes. That is good. It is good now.
That is good.
It is good. That's right. But now the real problem is this patella.
So the problem is the left knee.
No, this is a right knee. Same-sided knee. Because it had to be kept flexed.
The same side knee.
Same
Okay.
side knee. The same side knee. this knee had to be kept flexed for quite some time, and that is what has broken down. So it's the same side knee. But here you can see the flap, which is doing good.
What is the cause of this desiccation of the skin and the patella friction now?
Probably the knee had to be kept flexed, extremely flexed for a long time.
Or walking or crawling on it.
But it was she could not walk because she had a cross leg.
Yes,
correct.
Maybe
correct.
crawling on it resulted in this.
No. She was walking on a walker. She was not crawling on it. It's probably because we had to keep the knee flexed, hyper flexed for 3 weeks. And the knee to start off also, you can see there's a split thickness graft here. The skin there is not very good. So probably that was the cause.
Patella to be removed and reconstruction of the quadriceps if possible, quadriceps or tendon of the patella if possible. If not, just a splint for or orthotics to go on it. Maybe after removal of the patella, we can close the skin.
Correct. So we thought the first thing would be improve the wound. We did thorough debridement and put wax. You can see the wound has improved significantly. Then I had a very lengthy discussion with our plastic surgeon, and who said that I can raise this flap. Then you can mobilize the quadriceps, take out the pull-out sutures, and after you tie, I will turn the flap on the patella. So we said I'll be able to cover the patella. So that was the plan. Here you can see the flap that is marked. The flap is raised. That's the quadriceps tendon which is ruptured. You can see the patella is now quite decent. This is after we took out the pull-out sutures, and then the flap was rotated. And here now you can see the skin of the leg has improved significantly. That is, the patella is covered very well. Now we thought that we will give her some treatment holiday. She was lost for a follow-up for about 4 years, and then at 4 years, she tripped at home and presented with fracture of the lower end femur. The tibia is malunited, but she was still walking with a walker. She was still unable to bear weight on the right leg. So as a priority, we plated the femur. And then she said that, sir, please address my tibia also, which has not healed, because she had significant recurvatum and fused ankle. So she had varus, recurvatum of the ankle, and fused ankle. So this is where we are. The skin is much better now, but the tibia has a significant recurvatum. So I thought
the tibia had been corrected before or not?
That's right. The tibia needs to be corrected now. The only question was, how do we stabilize it? Whether you use an Alizadeh or whether, because she was very short stature, the tibial nail could not be used. So I thought I will excise the fibula and address the tibia from there. And I thought I'll use since the ankle was fused, I thought we'll use a retrograde humerus nail for fixation, because tibia nail was too thick for her. So that's what we did. The tibia malunion was completely corrected. Then at 3 months, we did plating on the medial side with bone graft. This is at 16 months. You can see her. She has a decent range of knee movement. The fracture is almost healed. This is at 4 years. All the fractures have healed well. So from a mal-positioned tibia with completely exposed patella and osteomyelitic patella and quadriceps rupture, this is at 4 years. We have a good cover of the knee, good skin on the leg, and a decent range of movement. So this is how we started. That's the cross-thigh flap. This is our own complication of exposed patella, necrotic patella, and a large skin defect. That is after we did a thorough debridement and vac. This is after pull-out sutures. This is when she had a femur fracture. This is when we decided to address the malunion. And that's the retrograde humerus nail we did because the tibia nail would not fit in. This is after doing a plating, and this is the final result. Yes, please. Any questions, any comments?
One comment, please.
Yes, please.
First of all, congratulations. This is a very dangerous, difficult patient. You see so many different surgeries. Italian plastica, intramedullary osteosynthesis, debridement, necrectomy, osteotomy, and so on and so on. Congratulations. Very good results.
Thank you.
But how is the function of the joints? So the knee and the ankle, do they move or they are stiff?
The ankle was fused when she presented to us. Totally fused. Ankle and subtalar were totally fused.
So it was fused and it is fused now. And the knee?
The knee has about 90 degrees movement. 0 to 90.
90? 0 to 90.
0 to 90. And she's completely mobile, walking on her own without support. Fractures have healed, as you can see.
Range of motion actively, 0 to 90, actively or passive?
Sorry?
The extension apparatus is working.
Extension, can she actively stretch the knee?
Yes, yes. She has good quadriceps power. Actively she can straighten. Actively she can straighten.
Excellent, wonderful.
If in a case like this, what about amputation as an alternative?
In our country, generally people don't prefer amputation, especially when the soul is sensate. They're just not keen on amputation.
Okay.
I mean, that would have saved a lot of time, agreed. But she was absolutely desperate to save the leg.
It's the same as our country.
Yes.
No, yes. I know that in many countries and even in our country, people, they don't like so much, but in some countries, it is very difficult to propose amputation. Yes,
correct.
I know.
Correct.
Correct. It is very important to have the compliance of the patient and of the family in front of this long treatment and the complications.
Correct.
In a country like Italy, for example, a complication like the one that you had in the knee would be extremely dangerous because probably they would not come to the same doctors. They would come to another doctor, and if they sue you for this complication, they win. And the reimbursement for this can be as high as $300,000 or $400,000.
That's right. That's it. I was lucky.
It's difficult to manage this kind of complications and to save the compliance of the patient and of the family.
Right. I was very lucky. I was very lucky. And every time the patient would say, "Sir, you can do it. Sir, you can do it. Please go ahead and do it." So I was, as I said, I was very lucky.
Interesting because it shows that the difference in the world, the social difference in thinking of the population, of the people, has a strong impact also on our techniques and possibilities.
Yes.
Right.
If they continue to trust you, at the end, you can solve the problem. But you need to have this kind of trust.
That's right. Absolutely. Absolutely. Correct.
Excellent. So
Thank you. Yes. Now I think we can go to the last presentation, last and the best, by Dr. Aditya Menon.
Thank you, sir. I'll quickly summarize this patient. I don't know if this is going to be the best, but there have been lots of unique cases. This is a pretty common scenario, but with a slightly different management at the end. I hope my screen is visible.
Yes. Can you make it slideshow?
I have.
No. No, it's not a slideshow.
Slideshow.
I mean, I did the same thing that I did during the trial, but okay, I'll try it again.
I could see it nicely.
What about now?
Go on. I mean, we can see the
screen. We can see the presentation, but not as a slideshow. We are seeing it as just on your screen.
I did the same thing that I did in the trial, but I'll do it again.
So you can run with your screen also. That's okay.
Yeah, I know that. I'm doing that. Yeah. This is okay now?
Yeah.
A little better.
Yeah. Now it's a slideshow.
Yes, perfect.
Young gentleman who came to us with a discharging sinus about 2.5 months after a road traffic accident. We trace the history. That's what we do with all patients. We go back to day one. He had an open diaphyseal fracture with posteromedial wound, which was debrided and sutured in the emergency department itself. So all this story had happened before the patient came to us. He also had a proximal tibia fracture. Both were plated about a week after the injury. Unfortunately, 3 weeks later, as is commonly seen in open fractures, he developed a discharging sinus proximally. They sent a swab, which was negative, gave multiple empirical antibiotics. That discharge dried up. We then developed another discharging sinus, about 2 months now. That time they did another swab. They got a pseudomonas, treated the pseudomonas with targeted antibiotics, and yet the discharge continued. And now he came to us at about 2.5 months with multiple sinuses, midshaft, distally, with the scars of the injury and the scars of the open wound. Now, obviously, at this stage, the questions that the family would ask and the things that we would think is, should we continue antibiotics? Should we do a DARE? Let's try and retain these implants, or will we have to do implant removal? So the factors which fell in for each of them, there is no place for continuing empirical antibiotics. That's out of question. We know we need to debride. The points in favor of a DARE was he had really no symptoms. I mean, very minimal clinical symptoms other than the sinus. The reductions look pretty stable. The implants look stable on the X-ray. The factors against a DARE was this was 10 weeks post-injury after an open fracture. Initially, if you remember, the wound wasn't explored in an operating room. In fact, the open wound was washed and sutured in the emergency itself. So very likely that really there was no actual debridement at the open site. And there were multiple sinuses. So our theory was, with a patient with multiple sinuses, proximally, midshaft, distally, and a different area of open injury, probably the entire medullary canal along these sinuses deep within was infected. And that's what we see a lot of times. A small discharging sinus with minimal symptoms, but when you actually go in, the entire implant and the biofilm has gone into the medullary canal itself. So all of those areas are probably infected. What we need to have is some objective evidence for this. And so we now, for the last few years, have been using a FDG labeled leukocyte PET scan. So this is an advancement of the regular PET scan where leukocytes are tagged with FDG and they're very specific for infection. It showed a lot of abnormal uptake along the entire medullary canal of the distal tibia, along the tibial plate, along the proximal plates, and that's exactly what we suspected. What it also told us was at the fracture site, there was some callus there, which was seen on the X-ray itself, but there was a transverse axial section where the infection was going along the interosseous membrane up to the anterior aspect of the fibula. So it helped us with our surgical planning as well. So now we knew there's a deep infection in the medullary canal. Sorry? Okay. There's a deep infection in the medullary canal, proximally, distally, along the interosseous membrane. So all of that needs to be cleaned up. So obviously, the implant salvage is out of question. We do involve the ID teams in all our cases of infections, and they started thinking on the lines of some slow-growing pathogens because the patient really had no symptoms. Staphylococci generally have a lot of symptoms, even with gram-negative, so they started thinking whether it's a fungi, a non-tuberculous mycobacteria, or a cons, especially because patient had an open wound to start with. So this was the surgical debridement excision of all the scars and sinuses, proximally and distally. The minute we removed the plate, there was a thick biofilm under it, and that had started eroding the medial tibial cortex. At this stage, we wanted to decide whether we should disturb the fracture site, open it up, and clean the canal. But with this medial cortex, what we could do is just make a long oval window, which gave us an opportunity to clean the medullary canal, which is just full of infected pus and granulation tissue. So a long medial window was made. The fracture site had already started stabilizing a bit. It was a gummy sort of a stability at this stage, so we did not disturb that. And we could achieve a good source control in the distal part of the tibia along the shaft fracture. Based on the preoperative leukocyte scan, we also knew that we need to take a incision along the fibula, where we address the infection on the anterior aspect of the fibula and the interosseous membrane. So this was planned preoperatively, measured from the ankle joint. And then we went to the proximal tibia, removed that implant as well, coalesced all the screw holes of the proximal tibia plate, made it into a nice big cavity so we could scrape out the medullary canal proximally, and sent for multiple cultures. And this is what we do in our institute. We send it for bacterial, tibial, fungal cultures, gene expert, and histopathology. I understand this would not be applicable to all the countries, but we do see a variety of infections. And although we do have a guess of what it could be, we ask for all tests and make sure that we don't miss out on some bacteria just because we've not asked for a particular test. We've also started using the BioFire GI panel, which does test 31 pathogens and tells us what the resistance patterns are. So within 8 hours, we knew we had a Pseudomonas. Same thing on tissue cultures and blood culture bottles grew after 4 days. So we knew what we're dealing with. In addition, the histopathology also told us there was granulomatous inflammation. So this granuloma is not a standard Mycobacterium tuberculosis. It's actually non-tuberculous mycobacteria, which is very common in open injuries. So the patient had a dual infection with a pan-susceptible Pseudomonas, for which simple oral ciprofloxacin was enough. For NTM, it's a completely different ballgame. They're tough bacteria. They require multiple antibiotics for a long course over 6 to 9 months. And implants fare very poorly in presence of these bacteria. They tend to form very aggressive biofilm as soon as some foreign body or a metal is introduced. So our priority was infection control, and that's what the relatives also expected, that they want a healed, clean fracture. They were very, very skeptical about any kind of internal fixation and malunion. They said, we are okay with the malunion, we can address that later. But as surgeons, that's not our primary goal. So what we did at this stage was, there was a soft tissue defect, a bony defect. We put in stimulant beads in the medullary canal with gentamicin. And the plastic surgeons then did a microvascular anterolateral thigh flap to cover this defect. This was the post-operative image, and this is at three months. The CRP had normalized, absolutely clean. Patient was walking with a walker. There was obviously some varus deformity at this stage, and we had this discussion that we must address this either with an external fixator or with internal fixation. Again, these are social challenges that we face, that they had obviously done their research about external and internal fixation and the risks faced with these bacteria, and this patient was still on therapy for NTMs, and they just refused to have any kind of fixation. And that's something that we discussed in detail and got it noted on paper. I think both the patient and us got lucky that there was no further deviation and the fracture completely united. And this is the patient at 1 year, mobilizing with no functional defect. He's doing all his activities. So we started with an infected non-union, created an uninfected envelope, which was then filled with by a multidisciplinary team, including a plastic surgery. And that's what we try and do with every case. So the solutions for every case are different. Here we got away without any kind of fixation, purely based on adequate debridement, adequate tissue sampling, and asking for the right tests, not missing out on bacteria. And we ended up filling the soft tissue defect and a consolidated fracture with no infection. So now he's about a year and a half, 2 years since the last surgery, and he's absolutely completely infection free. Thank you.
Excellent presentation, Dr. Aditya, and it was a very nice way of managing cases which we routinely see as compound patients coming to a lot of our practitioners. I have a couple of questions. The first being your biofire, which detects, does it not detect the non-mycobacterial infection? Because that you said you got it on the histopath, but not on your biofire. So
Correct.
does it not detect it?
So the JI panel has 31 pathogens. It does not detect NTM. It does not detect TB. So
Okay.
every panel has its limitation. It
Right.
will not be able to detect everything that's there. So that's a limitation, including Acinetobacter. So there are 3-4 common pathogens in India, which are a limitation for this test. So that's why cultures are also important. You cannot substitute anything for cultures.
All right. The second question was, do you use methylene blue like we do regularly whenever there are multiple sinuses present? We inject with methylene blue so that you can get to know the tissues in that area, what to remove and where is it going.
Correct. So that is a standard technique, but we don't really use methylene blue. Generally, when you excise the sinus, it has a nice sheath around it, and it's really separated from the normal tissue. So if you can put a small artery or a mosquito within that sinus and go, as long as you don't breach the wall, you can really remove the entire tract, and it leads you to the non-union site or wherever it is originating from. So you can just follow that sinus and fistula and go deep inside, and it'll also lead you to multiple small micro abscesses along the way.
Thank you very much.
Thanks. Thank you.
Anyone else has any question?
Do you think it was necessary to remove all that skin? Because the flap probably contributed very much to the healing, even of the infection. But did you do it, this flap, to heal the infection, or because you removed the skin? Because I'm not sure that it was so necessary to remove so much soft tissue coverage in this patient. Why did you do it?
Yeah. So flaps don't treat infections. The only thing that can treat infections is a surgical knife. So soft tissue, which includes scars, sinuses, which lead across all directions, everything that looks abnormal, and about half a centimeter beyond that must come out. So if that ends up leaving a big defect, like in this patient, so it's very deceptive. From outside, it looks like a very small sinus, but you end up removing a lot of tissue, and that's when you end up with a clean bed. So whatever the size of the defect after that needs to be covered, and that's why this patient needed a free flap. So anything less than this would have been inadequate debridement and probably would have led to a recurrence at some stage. So not all patients require such big defects, but this patient ended up with a big defect because of the extent of debridement that was needed based on the extent of the sinuses, based on the micro abscesses that were found deep inside. And that's classically seen with slow growing pathogens in NTM. They don't have any symptoms, and yet the infection inside is extensive. So the idea was not to create a defect to get a big flap. The idea was to get rid of everything, get an empty, clean bed, and then whatever is needed to fill that defect in this case was a free flap. And yes, flaps do add vascularity, so that always helps. But that wasn't the intention.
Okay.
So, Alizadeh, you'll have to unmute yourself.
Dr. Chingiz, please unmute your microphone.
Thank you. Thank you. First of all, congratulations, the very good results. After the synthesis with the plate, bone necrosis under the plate is sometimes observed.
Yes.
If we have fistula, for example, we in our clinic, we use the method of catefistulography using hydrogen peroxide. We talk about it in our meeting in Recklinghausen. This is very clear, demonstrative, and safe for the patient. Try this method, catefistulography with peroxide.
Yes, thank you.
Thank you very much.
Thank you for the question. We have done a few cases with fistulography. So it's a technique which is there in our part of management. But now specifically with implant-related infections, the PET scans do tell us much more about the intramedullary spread and around the implant. So gradually we've moved on from fistulography, but yes, we do use it in some cases.
Thank you.
Thank you.
Excuse me.
Dr. Fadel has a question.
Weighing or equalization between the redissection of the already had been dissected area to extract a few points of infection according to the outcome of the investigation. I think that the weighing the pros and the cons or the benefit of this to disrupt again the soft tissue to pick up those points. It is also serious to disturb the biology of soft tissue to work. I wonder if this is also in your mind while you are applying this redebridement, and also for those fistula or for those screws penetrating the bone. Are you obliged to unscrew them, redrill, and put another screw or something like this? Those 2 points only.
Thank you for the question.
Disruption of the soft tissue to pick up those scattered points of infection. The outcome of disrupting this biology, I think weight, I think it is important also as you are doing to this infected, this infection by picking up this. You destroy, not you, yeah, this technique destroys the soft tissue that had been already covered for a long time, for keeping the vascularity in this area, for combating infection, for getting union of the bone. So we are disrupting this biology by exposure again and picking up the points of infection.
Yes,
is it horrible infection to do this aggressive maneuver to open again all these line of dissection to get rid of this unresponded infection field, or the field could be managed by something easier than this? Your opinion, just your opinion.
I'm sure there are more ways of managing this. This is how we managed it, but if there are lesser traumatic ways, I'm sure we're open to learning that.
As the same question I asked a colleague here in Egypt using this technique. And the other thing is that it is in Egypt. It costs too much. I didn't know how much it cost in India.
Now, can I just interrupt? I was also there when Dr. Menon operated this case, and the plate was absolutely loose because there was a full dirty granulation tissue underneath the plate with complete destruction of the cortex. So that is why the complete plate had to be exposed, and that large window that you see is actually just came out with artery forceps. The cortex was totally eroded. We really didn't have to make a window with osteotome and hammer. It just came out with artery forceps. That's why you see such a large window.
But Vikas, I think it's not the point. It's not the window made in the bone, which is logical and needed. The point is if it was necessary to remove all those soft tissue for maybe 5 centimeters, it is something that if you have a good plastic surgeon that can do without any problem a large flap, you can do. But in many hospitals, in many situations, it is also possible in a case like this to be more conservative on soft tissues, and probably the results could be good all the same. Because even if you don't do such a large flap, the big problem is the infection of the bone. Once you remove the hardware and you clean the bone and you make this large window, then you can also close directly the skin. Because the fistula, they are a symptom of the infection. So it's not necessary that you stay as in a tumor 3-4 centimeter larger than a fistula. Usually, at least, it depends on what you find at surgery, of course. So I think in your facility, you have a very, very advanced team with nuclear imaging, with genomic identification of bacteria, with good plastic surgeons. This is very, very peculiar. It's not for everybody. But a case like this could be managed, even, in my opinion, even in a medium-sized hospital, even without the plastic surgeon, I think.
Possible. I agree. Different ways of managing the same thing.
How much it costs? It costs in India.
Yeah. But the cost, the logistics, yes, everything should be taken into consideration, of course.
In Egypt, it is so much.
That's right.
Okay.
But this is very, very. We should run and follow every new in the field of combating infection.
Right.
So we should run and follow it and try to explore more and more. Congratulations for you and other colleagues who do this.
Excellent. Ma'am, you want to say something?
No, I was just about to say that I think Ashish will be proposing the vote of thanks. Just that I really admire the dedication and the sincerity with which all the faculty have really brought out the best points in every case. So I think that's been really wonderful.
Excellent. Thank you, ma'am. Thank you very much. And
thank you.
Our privilege to give you a vote of thanks. But before that, I would just like to say something very personal. When we were training, one of my mentors used to say, Ashish, what is the difference between osteomyelitis and true love? So today, I think I'm proven wrong. My perspective about chronic infections has changed after seeing such well-managed, complicated cases. And this really pushes the our academics to a different level. about cases that will really benefit our members when they watch it on our YouTube channel, which has got a subscriber base of about more than 3,500 members. And this will, of course, be appearing on social media again and again. So thank you very much, WAIOT, and Dr. Romano, Dr. Chingiz Alizadeh, Dr. Fadel, and Dr. Heinz Winkler, and our dear Dr. Vikas Agashe sir, and Dr. Aditya Menon. Thank you very much for that. I would also like to thank Dr. who has been behind us and trying to get everything in order, along with our keen webmasters, Dr. Gaurav, who is managing the YouTube channel, and Dr. Agnivesh Tikku, who is there on the Zoom and managing the Ortho TV at the same time. Dr. Jayesh Baviskar, our EC member, has been very active, and he is also helping us organize the whole thing. And finally, thanks to Ortho TV, who is helping us take this to thousands of orthopedic surgeons all across the world. And they have been very supportive. They are our media partners, and we look forward for their active participation henceforth. And finally, our sponsors, Torrent Pharma, who have been very gracious in supporting our academic activity. Thank you very much. Good night to all of you. And again, I would like to welcome you to our annual conference, the WAIOT, and you'll hear from us very soon.